So look at this slide. If any patient came to you with polyhydramnios already detected on the ultrasonography, then you have to follow 3 key steps. One is detailed ultrasound for the fetus, another is maternal investigation, and another is to assess the risk of preterm delivery. So in detailed ultrasound for the fetal, you have to assess the fetal abnormalities, fetal weight, fetal stomach size and shape, and fetal movements. If any concerns arise like fetal congenital abnormality, fetal aneuploidy, fetal infection, small for gestational age baby or IOGR, or concerns regarding the movements, you have to refer the patient fetal medicine specialist team urgently. Additionally, you have to do the maternal investigation like glucose test, random blood sugar, glucose tolerance test, and HbA1c. And the infectious screening for toxoplasma, cytomegalovirus, and parvovirus. Next is red cell antibodies to check the alloimmunization. So if maternal diabetes, infection, or red cell antibodies detected, then you have to refer the patient maternal fetal medicine specialist team. Next step is consider antenatal status if any cervical shortening present on transvaginal ultrasonography. And also you have to counsel regarding the risk of preterm labor, unstable life, cord prolapse, antepartum and postpartum hemorrhage, and increased operative interventions. Ultimately, management depends on the underlying causes. If a maternal or fetal abnormality is detected, treatment is tailored accordingly. In case of unexplained polyhydramnios, I will show you another slide. So here is unexplained polyhydramnios. If any patient came to you with unexplained polyhydramnios, you have to follow this flowchart. You have to assess severity using AFI. If AFI is more than 35 cm, this is severe polyhydramnios. If AFI is 25 to 29.9 cm, this is mild. If AFI is 30 to 34.9 cm, this is moderate polyhydramnios. So if polyhydramnios is severe, persistent, or worsening, and if any fetal abnormalities, you have to refer the patient to fetal medicine specialist. If there is any maternal discomfort, respiratory compromise from the polyhydramnios, or risk of preterm labor, you have to go for therapeutic amniocentesis and amniodrainage. When you have to solve the clinical scenario, they will give you in details, then you can easily understand what will be your answer according to this flowchart. So in case of mild and moderate, you have to do serial growth scans to monitor the fetal well-being and transvaginal sonography for cervical length. There is no benefit from induction of labor for isolated or unexplained polyhydramnios. We will go for induction of labor only for maternal or fetal indications present. Then during labor, you have to monitor progress of labor and watch for complications, especially shoulder dystocia and postpartum hemorrhage. After delivery, a thorough neonatal examination is essential to check neonatal anomalies and check patency of upper GI tract using nasogastric tube, as polyhydramnios may indicate esophageal atresia or other anomalies. These two flowchart is very important for the exam for any clinical scenario.